Good afternoon and welcome to today's webinar hosted by Region 10 chapters of HFMA. The topic for today's webinar is Top 10 Trends in Reimbursement Disputes. For today's presentation, I'd like to welcome two guest presenters for today. We have Colleen Faddick as well as Ross Burris III, both shareholders of Polsinelli PC. Colleen Faddick advises clients regarding the structure of and relationships among healthcare providers and entities within the complex federal and state regulatory environment. She currently serves as chair of the firm's healthcare operations practice and focuses on Medicare and Medicaid reimbursement and enrollment issues and appeals, fraud and abuse, and self-referral law issues, licensing and certification of healthcare entities. Ross Burris III benefits clients by applying a strong business acumen to understanding the goals and challenges clients face and by leveraging a commanding ability to counsel on intricate legal issues. His expertise includes advising clients regarding the complex and ever-changing federal and state regulatory environment. So with that, I'll hand the call over to today's guest presenters. Colleen, I believe you're up first.
I am. Thank you very much, Nikki, and thanks everyone for joining us today. Feel free to ask questions by email or at the end, and we are happy to address those as much as we can. So today we're going to talk about some top reimbursement trends. Many of those are dispute related. Some are just basic reimbursement issues. Of course, nothing in Medicare is basic because that would be too easy. So we are going to address these kind of along the lines of government payers, commercial payers, and then Medicaid. And if you are following along on the slides, you will, and if you actually count, you will see we only have 8 top reimbursement trends rather than the 10 that we advertised. So we're hoping some of our listeners will pipe in with a few more. So with that, Ross is going to get us started on some litigation aspects of reimbursement disputes.
Thanks, Colleen. So the first thing we're going to talk about today is somewhat new concept of contesting recoupment while you're seeking appeal. So what we're talking about here is providers who have been hit with an overpayment demand by Medicare. And ordinarily, they have to go through a 5-step appeal process. At the first 2 levels of appeal, redetermination and reconsideration, it is possible to stop recoupment. That is, it's possible to stop the government from offsetting your payments or seeking other recoupment methods of recovering the payment while you're still on appeal. After you hit the 3rd level of appeal, it's no longer possible to stop recoupment, and the government will begin to offset your money, or you have to work out a payment plan, or you might have to go figure out a way, or in some cases, they'll even get the Department of Treasury involved, and they might come after you through more aggressive collection measures. So obviously, this is a big problem for providers, especially those who have a lot of money at stake in their demands. So people who are facing multi-million-dollar demands and don't really have the revenue to cover the cost and refund it now and while they wait for their appeal, it can be a company killer. And this is something that our clients have struggled with for many years. And previously, typically when clients tried to seek any type of administrative relief or judicial relief, rather, they would meet with dismissals from the court because they failed to exhaust their administrative remedies. And what the court is saying there is, unless you've gone all the way through the appeal process, you can't bring it to the district court. This actually changed recently, and it's very somewhat exciting, to at least to lawyers, because a group out of Texas brought one of these cases and was able to actually get a TRO, and I want to tell you a little bit about that. So if you're familiar with the appeals backlog, and I presume if you're on this call you are, at least vaguely familiar, you know that the current appeals backlog for a group that's appealing something like a RAC or a ZPIC audit, or even just a large overpayment demand, or the wait time at the ALJ is somewhere close to 3 years. And so that means it can take you 3 to 5 years to get through the appeal process, because the first level can take first couple levels can take almost a year, and then obviously the DAB and district court is even further. So it's very frustrating to companies that have been recouped against because they don't get their money back for a long time. It's very frustrating for companies that can't afford to lose their money right now. And the AHA brought a case, American Hospital Association, against HHS a few years ago. But in that case, they just brought it against HHS to fix the backlog. They basically said, court, help us figure out a way to make HHS speed through these cases sooner. Family rehabilitation did not take that approach. When they came to court, they said, look, we're not getting to the merits of our case. We're not saying that we're going to win or that we should somehow jump the line on appeal. We're just saying that we should not be recouped against until we get our day in court. And this is a big deal for this company. I mean, they got a $7.8 million extrapolated demand. And this is from a ZPIC coming in auditing to 43 claims, which is incredible. They looked at 43 claims and suddenly decided that this company owed $7.8 million. And they were claiming a 93% error rate. So not surprisingly, as is often the case, the provider lost at the first two levels of appeal, but then they went and sought the TRO. And when they sought the TRO, they said, Judge, we will be suffering immediate harm in the form of laying off 89% of our staff and only being able to serve 8 of our previous 289 patients. I mean, just a blow to healthcare and to patients in general in this area. In fact, chances are the recoupment is going to bankrupt the business. As the court had done, it followed precedent and said, look, and the judge was sympathetic, but basically said, look, I can't help you. I'm going to dismiss your case because you failed to exhaust administrative remedies. Well, this group appealed, and they took it to the circuit court, the next court up, the appeal court, and what they said there was, you know what, we think this issue is actually a collateral claim to the underlying problem related to the whether the claim should be paid themselves. The recoupment is a separate issue, and we think that a court could issue a TRO, and that's a temporary restraining order on that issue. I forget that unfortunately, I can't see any of you, and I don't know who you are, so I don't know if any of you are lawyers or any of you are, familiar at all with the law. So, forgive me if I'm, talking around issues that you don't understand, or if I'm over-explaining things that you find extremely elementary. But just for everybody's edification, a TRO is an injunction. It's going to the court and saying, please, court, tell CMS they can't take our money back until something happens. In this case, they said until we've been through the appeal process. So the exciting thing is that after the circuit court issued this ruling, they came back and they said, the district court looked at it again and said, fine, we're going to give you a TRO. CMS cannot recoup against you while you're on appeal. And here's what they looked at, and this is important for any of you who are in a position where you're facing a tremendous recoupment and you believe it's going to be company crushing. You can look at things like a substantial likelihood of success on the merits. And I think to show this, most groups would show their previous appeal success rate or audit success rate, substantial threat of immediate irreparable harm for which there is no adequate remedy at law. Well, in this case, this group showed, well, we're going to have to lay everybody off and possibly shut down the company and not take care of a vast majority of our patients anymore. We won't be able to afford it. And the third was that a greater injury will result from denying the temporary restraining order than it is if it is granted. And think about this. So basically what they're saying is you can taking back $7.8 million from us is going to destroy us, but the government can live without the $7.8 million for a couple more years. Who is the greater harm to? And then finally, does a TRO like this to serve the public interest? And Colleen and I were talking about this earlier, and a lot of these providers are providers in the rural areas. It could be a critical access hospital who's the only facility for 100 miles, or it could be the only home health agency in the whole town. So shutting down these companies can really disserve the public, and certainly granting a TRO will not harm the public. So it's good that this was granted for this particular group, and as you can imagine, a lot of the other groups followed suit. One of them is Accident Injury Rehab, and that's a South Carolina chiropractor, actually, and holistic medicine group. And they asked for the same relief and were granted the same. A couple interesting things about them is they were seeking, the government originally sought $6 million and had already taken back almost $2 million by the time they got this TRO. And they were suffering. They'd already had to terminate 24 of their employees. So the court sympathized with them there, but as you can imagine, CMS has appealed it, and to my knowledge, that has not been decided upon. Second case, and this was actually the second case that came out. We have them in alphabetical order, but the second case that came out was Adams EMS, and this is another Texas case, although Southern District, not Northern District. In that case, once again, they stopped recoupment of $401,000. So it doesn't even necessarily have to be a ton of money if you can show that it's a company killer. And in this case, this company showed that they were forced to sell assets and reduce workforce to 2 employees, and they were also facing bankruptcy and closure if this recoupments were allowed. So we're kind of rolling along and getting some really good decisions on this, and the provider community especially is getting very excited. And then Alpha Home Health Solutions came along, and my apologies to anybody from Florida, but Florida, although it's by no means West, is always sort of a bit of the Wild West when it comes to judicial decisions sometimes. And in this case, the Middle District of Florida denied a TRO request. And the problem was they didn't just deny it because they didn't think there was substantial, well, they didn't just deny it because they didn't think that the provider needed it, meaning that they didn't just say, hey, we don't think the provider's in that bad a shape, they can handle recoupment. No, here they actually said that they did not demonstrate a substantial likelihood of success on the merits, and therefore in finding that, they said that the provider did not have a, quote, constitutionally protected interest in overpayment of federal claims and federal funds. So basically what they said is you don't have an interest to keep money that's owed back to the government. Now, Colleen and I would dispute this, saying, well, we don't believe the money is owed back to the government. We believe this was properly paid, so it's absolutely our property right. But that court did not agree. They also said that there was no irreparable injury, which was disturbing, because there they said that the providers take on the knowing risk of payment might be delayed by Medicare when they choose to sign up with a Medicare program, which I don't really agree with or think is fair either. And this case is currently on appeal with the 11th Circuit. Do you have any comments on that, Colleen?
Well, I think Ross's point is right, is that whenever you look at an overpayment, if you appeal it, the point is that you disagree with the government's position on that, and there is an appeal process and a mechanism designed to do that. And when it hasn't been finally adjudicated, it's pretty difficult to say that the hospital, knows that that is an overpayment, because our position on appeal is obviously we disagree with that. So we think the court's reasoning in that case is way off, not only for purposes of a TRO, but just for the basic analysis of is something or is something not an overpayment. And just because CMS or a MAC thinks that it is an overpayment does not mean that it is so. And an appeal that hasn't gone through the process and there's no final decision, you can't fast forward or move that decision forward and say just because the government said so that it is in fact an overpayment. So yeah. I think that's disturbing to us.
The analysis there is really disturbing, and the problem is, of course, and you don't have to be a lawyer to realize how CMS might use this kind of case against other providers who are seeking this kind of relief. So it is troubling. We were kind of running smoothly there for a while on these cases, and then this one came along. But hopefully we'll see some better decisions from them on the circuit.
It is a minority at this point.
Right.
So that's
right.
Good.
Yeah. And you still have the circuit court case too, as opposed to 3 district court cases. So next topic I want to talk about is, can a duty to self-audit and report be triggered by a government notice? And you're probably thinking, what in the world is this dude talking about? Well, I'm going to tell you. So in 2018, the OIG issued a report to WPS, the MAC, and found that upon its own review, OIG's review of 2000 and 2014 claims related to hyperbaric oxygen chambers, it had decided that there was a substantial error rate in whether WPS should have paid these claims. And let me tell you a little bit about what they did. They took 120 claims from the entire MAC. So from all the, so they didn't take 120 from each individual provider. They took 120 from the whole MAC total. So many providers didn't receive any requests at all, and those who did, received a handful at most. And they reviewed this quote random sample and then extrapolated it out to a universe of 44,000 claims, which they believe to be about $59 million in paid claims to these hospitals. And when they looked at it, they decided that 102 of the 120 claims were paid improperly. They did not meet Medicare requirements. So we're talking about an 84% error rate. And they sent a note to WPS and saying, we think you overpaid these providers in your area by $42 million. Now, rather than WPS looking inward and finding out maybe, what mistakes they might have made or things that they could have done differently, of course, they flipped this directly to every provider in the MAC that provides these services and says, hey, OIG thinks we have an 84% error rate, and therefore you should consider this notice credible information to go back and review all of your claims and refund any errors that you find, any overpayments. And we will remind you that under the 60-day rule, you have an obligation to self-report any overpayments, and if you don't, they could become subject to the False Claims Act. Well, as you can imagine, this was very distressing to almost every group, I'm sure, if not all of them, mostly because most of them hadn't even received a single document request. So they knew for a fact none of their claims were even reviewed. And those who had not received more than a handful, certainly nothing that would be considered a statistically valid sampling of their claims. So it's a very troubling and quite frankly lazy way to audit, in my opinion, because they're not actually looking at it themselves. If they had a true concern about this, they could have designed their own MAC-wide audit program to go in and look at bariatric claims with that they believe to be potentially overpaid, and that's not what they did. They just turned it all back on the MACs. What do you think about that, Colleen? How would you react to that?
So what's mostly concerning here, well, I should say one of the things, is that every aspect of this is wrong. So when you do an audit, you're auditing your own claims, you're auditing information that you have as a hospital, and you would pick a probe sample or a statistically valid sample, wherever you are in the audit process, and you may or may not extrapolate through your own claims. Here, this was done at a much higher level, so some provider claims were reviewed, some weren't, and the extrapolation was across providers, not within a single provider. Mm-hmm. So every bit of that process is wrong, and the suggestion that some providers in the WPS jurisdiction may have billed inappropriately somehow gives you credible information of a billing error that must be refunded, takes that identification of an error to a whole new level. And I don't think that's required in the statute. I don't think that's required in the regs. And so I do think providers have a reasonable basis to say, that's not us.
Right.
Now, they may, because they were notified of a potential for erroneous claim submissions, they may put that on their audit schedule. Sure. And have the compliance department look at that in due course. But I don't think it rises to the level of actually identifying an overpayment by any stretch.
Yeah, I think that's right. And I've talked to some folks who that's exactly what they did. They treated it like any other audit question. Like, hey, we got a question from one of the billers on this thing. We'll put it on the audit schedule. We'll treat it like anything else. So the reason this is troubling is this is not the first time a MAC has done this. One of the DMACs did something similar several years ago. And I wouldn't be surprised if we saw this again, this sort of, maybe not on a MAC-wide level, but for individual operators where errors may become apparent through other types of auditing and research. I wouldn't be surprised if we saw MACs in other payers, quite frankly, try this thing again. Colleen, do you want to talk about cost reports?
Sure. So I'm going to talk specifically a moment about uncompensated care, the audits of the S10 worksheet in the context of disproportionate share or DISH payments. And I want to talk about this because new things are happening and a little bit disturbing trends are occurring in those audits that I think hospitals need to be very aware of. So, you know, as you all probably know at this point, DISH is moving or has moved to a slightly different formulaic methodology for payment, and the old percentage, disproportionate patient percentage formula accounts for 25% of the payment, where the remaining 75% is based on some notion of uncompensated care. And that, of course, is not perfectly well defined, but the GAO in various reports has raised concerns that the DISH formula as a proxy for uncompensated care is not accurate enough, and CMS should be far more diligent in terms of trying to figure out how to make those payments more directly relate to a hospital's actual uncompensated care costs. So that process is moving along, and what happens at this point is that a chunk of that money in the 75% category is a fixed bucket of cash. So that pie gets distributed and redistributed among hospitals. There isn't any more money to be had. So some hospitals are going to win, although probably very few. Some are going to lose. And how you win or lose may not, in fact, have anything to do with your actual uncompensated care costs. And so the move that we are seeing here is really towards the use of S10 data, which is the worksheet on the cost report that hospitals identify their various forms of uncompensated care. And historically, although that worksheet was filled out, it wasn't really used for anything. And so I think the level of diligence hospitals paid to that report was probably a lot lower than it now needs to be. So now the MACs, starting last fall, have really started to audit the S10 worksheets. And the problem with that is that only certain hospitals are being selected for audit. And then within that audit grouping, the MACs are taking different positions on what they're auditing and what outcomes they are achieving. And so you get winners and losers just from the very fact that some hospitals are audited and some aren't, because if you're not audited, then whatever you put in as your uncompensated care cost will be taken for what it is stated, and that value will accrue to the hospital, however that is calculated. And if you are audited, the chance of portions of those claimed costs being disallowed increases quite a bit, and so you're likely to lose just on the basis of being selected for audit. Worse than that, though, are these different positions that the MACs are taking, and some of them take the position that, for example, you cannot claim any co-payment charity care write-offs, even if those were the subject of your financial needs policy assessment, because it's not co-insurance as the instructions for S10 describe. So they're drawing really meaningless distinctions between co-insurance and co-payments, because Medicare uses the term co-insurance for beneficiaries who obviously owe the 20% co-insurance on their claims, whereas other private payers may use the term co-payments as opposed to co-insurance. So those types of varying positions can be very, very destructive to a hospital's costs in the uncompensated care column, and we need to be mindful of that. The second reason to really pay attention to this is, as we all know, Senator Grassley and others have been on a bit of a roll in terms of focusing IRS attention towards not-for-profit hospitals and whether they are actually providing appropriate levels of charity care to earn their not-for-profit status. And so we've now got this new scrutiny on worksheet S10, and is that data going to match what you put in your 990? And are we counting things correctly, appropriately, consistently? And can those two documents be used against a hospital because they are inconsistent? And, you know, we have yet to see that, but I think it is something that we need to pay attention to. So the next topic I want to talk about are CMS enrollment actions, which are really revocations and terminations, and then we'll hit some provider-based issues. So as I'm sure you all know, CMS has broad authority to deny, revoke, or terminate a provider or supplier's enrollment. Some of those reasons are obvious and would not surprise anyone, and that is if you've been convicted of a felony, you are likely to get revoked or denied enrollment in the first place from Medicare and state Medicaid agency enrollment situations. Some reasons are highly technical, and there are some that are characterized as an abuse of billing privileges without, for example, a lot of definition about what that really means. But what's interesting is all of these reasons are discretionary. And so for years, CMS has really limited its revocation activity to what we would call the more egregious situations, and the felony convictions, which oftentimes relate to fraudulent billing. Some of them are other extracurricular activities outside of Medicare, but certainly a fair number of those do relate to Medicare billing and dealing with beneficiaries inappropriately. But what we have seen on the rise in the last year to 18 months is CMS increasingly exercising their discretion to revoke, terminate providers for some of the more technical reasons. And one of the more common ones is identifying various provider and supplier actions as an abuse of billing privileges. And I will give you an example that's fairly recent, one that we dealt with that was a little bit surprising, and that was a licensure lapse of a licensed person who had the ability to individually submit claims, and that person failed to renew their state license. But because they had two state licenses, the person knew that, obviously renewed one but didn't renew the other, and didn't know about it, actually. There was no notice from the state that they had failed to renew the second license, and so this went on for a period of time. When the provider figured it out, the monies that were paid during the licensure lapse by Medicare were refunded, and it was a tiny amount of money, less than $10,000. And we thought that was the end of it, but about 8 months after that, we got a notice that CMS was terminating both the licensed professional and the group that the person was attached to, she had reassigned her benefits to that group. And the description was an abuse of billing privileges. And remember, this is less than 10 grand, and we refunded the money, but CMS's position without apology was we consider 3 instances of erroneous billing to be a pattern or practice of abusive billing. And so that very much caught our attention because 3 errors is pretty common. In fact, it's probably hard to go through a single day without making 3 errors of anything, let alone Medicare billing. So that is pretty surprising to us, and it took a fair amount of heroics to get that overturned. And I think it really highlights the notion that we have to be very diligent about our providers and supplier, especially individuals who have licensure lapses, how we handle that, repaying it where it's necessary, but that won't necessarily end your termination or revocation action.
I mean, that's a really aggressive use of that term, because when I've seen that characterization before, I've seen it in context of like billing dead people. And, which is, the example. In fact, I think there's a case out there where they talk about the 3 and it relates to billing dead beneficiaries. But this is something that must happen in hospitals and other facilities all the time, where nurses or whoever, has a lapse of license of some sort. So that seems really aggressive to call that an abuse.
Right. And that discretion, we would have expected CMS not to exercise, because it wasn't very many claims, it was very few dollars, and the provider, in fact, repaid them. So it really made no sense for CMS to exercise its discretion.
And we disclosed it.
We disclosed it. So, it is bizarre, and we've thought a lot about why are we seeing this? Why is CMS choosing to exercise its discretion in some of these instances where we don't think they would have before? And the best answer that we can come up with really came from one of our policy folks, and that is that there's so much pressure on CMS as an agency, along with other agencies in the administration, to reduce their budgets. And Medicare, as you all know, is really a fixed annual budget. And so the idea is that if you take from some, you give to others. It's not really a true savings in that sense. And so how do you get true savings? Well, if you kick out a bunch of providers who are unable to bill for a period of time, and they go through the appeals process, which takes, as everyone knows, forever, that's a period of time where payment isn't made. And it seems crazy that that would be the reason, but I have honestly not been able to come up with anything else.
Yeah. And the revocation appeal backlog is getting as great as the other one, at least ones we've seen go on for quite a while.
I think that's right. And so you really have to pay attention to these. Don't miss your appeal deadlines, because if you do, in CMS's discretion, they are not going to allow you to identify reasonable cause for missing those deadlines. They don't think anything's reasonable. And, honestly, it's a different tact than we've seen historically from CMS. So moving to provider-based issues, I'm going to talk only really about one aspect of this. I know we could go on forever about provider-based issues and site-neutral payments and where all of that is, but I'm going to assume everybody has talked about that and heard about that for quite some time. So what I want to talk about is scrutiny and denial of provider-based attestations. And even before the denials, some of the MACs have recently really been pushing back on what we will call space sharing concerns. And this has been going on for a long time. There is no regulation in the provider-based rules that prohibits space sharing. This is more of a guidance concept that came out of a CMS regulator or policy person's view on the survey and cert side, that some combination of the provider-based regulations and the Medicare conditions of participation prohibits space sharing, and how that was then defined was really up to, kind of a single person's view of what that meant. So we now have a new person in that role, and the new person is David Wright. He's the Director of Quality, Safety, and Oversight of the Survey and Cert branch, and he's taking a bit of a different position. He has spoken about this position twice now publicly, once in November on a webinar, and again last month at the AHLA Medicare Medicaid Institute. And he's pretty clear in his view that he wants to loosen the prior determinations, or, views, I would say, interpretations of what is considered inappropriate space sharing, but really from the survey cert side, because he's not on the payment policy side. So he doesn't make determinations with respect to true provider-based rules. So some of the things that he has talked about is moving away from that very rigid separation and allowing potentially things like shared walkways, shared hallways, shared elevators, shared registration desks, being able to lease space to physicians on a part-time basis. So while his view of this is not limited to the rural provider setting, he certainly describes the difficulties rural providers have in getting access to specialists. And so if you can get a specialist to show up in a rural community twice a month, and they see patients half a day twice a month, and they can lease space in an otherwise hospital outpatient department. One of the areas that David Wright still remains and has some concerns about is the notion of commingled staff. And so having totally separate shifts, somebody working Monday, Wednesday, Friday for a hospital, Tuesday, Thursday for a physician group or another hospital, he thinks would probably be okay, but not sort of the as-needed approach where you're roughly in the same building, and if you get called to the hospital outpatient department side of the house or the physician side of the house as needed and work it that way, he's far less convinced that that's okay. Also, he does not believe that a patient having to walk through patient care space would be appropriate when they need to get to non-hospital space. When and if this guidance comes out, there will be an opportunity for stakeholder feedback. This is not a rule, so it's not notice and comment, but it'll be far less formal and probably by email. So I think those are options, but we have some hiccups in the road here. The OMB just issued a memo to all the executive agency directors telling them that they have to send all guidance materials, which this would be, to the Office of Information and Regulatory Affairs beginning May 11th for review before publication. It is unclear whether this piece of guidance is caught up in this bucket. It's also unclear what that review would be and what limitations may be put on this type of guidance before it can be public. It's really unclear how this is going to play out. This, of course, would be positive news for providers. So a little bit interesting if this gets caught up in the anti-regulatory view of the world when this one actually is good. So we'll see what happens there.
All right, thanks, Colleen. I'm going to talk a little bit about strategies to reserve rights to correct payment for 340B underpayments. And what I'm talking about here specifically is for those of you who work at or assist 340B providers, this is for the 340B drug payments. What happened in 2018, they passed a new reimbursement model that reduced the payment to hospitals to less than 22.5% of the ASP, which is the average sales price. And just for some reference, what they were paid the previous year was ASP plus 6%. So this is like a 28% cut to these providers, and it was huge and obviously very, very harmful. And when you think about who 340B serves, these are nonprofit hospitals generally, right? These are not generally wealthy organizations that can afford to have a lot of reimbursement cuts. But in any case, AHA, the American Hospital Association, came to the rescue and brought an action against HHS, and the district court in DC found that the secretary had unlawfully exceeded his authority in establishing the new payment model, which was great news. Unfortunately, the court did not find or come up with a methodology to actually remedy the issue. So in other words, they said, yep, that rule is wrong and it's going to be struck down, but we're not going to tell you how these groups are going to get repaid for 2018, which left everybody in a really big predicament. And this, just for those of you on the phone who care, this was taken to the circuit court. The circuit court remanded, and they remanded it for HHS and AHA and the other involved parties, interested entities, to submit briefs with their suggestions on how to remedy it, and none of those have been accepted yet. I know AHA is proposing a methodology where these groups would probably just be paid in additional sums over the next couple of years, or additional percentages over the next couple of years to kind of make up for the lack of 2018. So in other words, HHS or CMS isn't going to have to just cut a check when this is all over, because they don't have the funds to do that way, or at least not without taking it from other people. But that's what AHA has proposed. We do not know what the court is going to decide on that, which leaves everybody in the very difficult predicament of having received underpayments, known underpayments for all of 2018, and now there's the question of, do we need to appeal them? And the American Hospital Association, who's sort of been driving this on behalf of the hospitals, has come out and said, yes, we think you need to appeal every single one of those individual underpayments. And I'll tell you, one of my 340B colleagues just pointed out to me that even HHS referenced that hospitals have an ability to appeal these underpayments in some of their briefings related to this case. So unfortunately, as onerous as it may be, that is the recommendation to hospitals right now, is that they go back to 2018, find all those underpayments, and appeal them all individually. Obviously, almost all of them are going to be out of time at this point. For those that are out of time, you will need to argue that you could not have known that this rule would be struck down earlier and that you appealed as soon as you could, although I will say the longer you wait, it's almost May now, the rule has been struck down for almost 6 months. So the longer you wait on that, the more problematic that argument is going to be. Not surprisingly, a lot of hospitals have or don't have the capacity or the ability to file this many appeals at one time. And to complicate things, several of the MACs have come out with statements and said, hey, WPS is one, Palmetto GBA is another. They've come out and said, hey, if you appeal these underpayments, we're just going to dismiss them summarily because we don't control the rate. That's a CMS issue. AHA says you need to appeal it anyway. You need to appeal it up to the QIC, the second level of appeal, and then perhaps even beyond to the ALJ, because we believe that they could hear it, or at least if you allow it to just be dismissed, then you're essentially losing your appeal right. So some hospitals have taken the approach that they're going to be a little less prudent or a little more aggressive in their, however you want to look at it, less prudent or aggressive. They're kind of opposite sides of the same coin, and say, you know what, we're not going to appeal every claim, but we're going to send a letter to the MAC and say, we believe this is appealable, but the only reason we're not doing it is because you say you're going to just reject it summarily, so we're just going to avoid the time and cost of doing that. Certainly, you can try that approach, and in fact, AHA has some templates out there on what that letter might look like if you care to look it up. But I don't think you'll be in the strongest position procedurally, at least later on, as if you had just filed an appeal, hopefully within a timely filing. So keep that in mind. This is an issue that is kind of brewing out there for everybody, and if you have a lot of 340B payments, you do need to make sure that you're preserving your rights as best you can. Next issue is new commercial payer policies designed to prevent pass-through billing. And I know, Colleen, we only got about 12 minutes left. Do you want to give a little bit of the history of what they're talking about with pass-through billing and what we think the commercial plans are doing here with regard to copying CMS?
Sure. So, you know, under arrangements is a concept that has grown out of the Medicare inpatient and now outpatient prospective payment systems, where hospitals are not allowed to bill separately for services furnished to hospital inpatients and outpatients. And so this prohibition against unbundling really requires hospitals to furnish directly or indirectly under arrangements a all services that the hospitals need to furnish to their inpatients and outpatients. And so directly usually means through employees or independent contractors. Indirectly typically means a contract with a third-party vendor. And this has been a long-standing part of hospital operations. It's been part of the Medicare rules since the early 80s when the prospective payment system was adopted. And so this is really part and parcel of how hospitals operate, and they increase efficiency, reduce costs, and really take advantage of specialists in certain areas by furnishing services under arrangements. Despite that long-standing way of operating and a methodology that's fully ingrained into hospital operations culture, private payers are now taking a very different view of that and essentially saying we're not going to pay for services that the hospital does not directly furnish. So those under arrangement services to some private payers now become non-payable to that provider because that provider didn't furnish them directly.
Yeah, so what they're doing is groups like Blue Cross and Aetna have sort of keyed into the way CMS has looked at these things. And frankly, you can call it budget or you can call it cost savings or whatever it may be, but it appears that they've seen an opportunity here to perhaps cut their own costs by no longer paying for these types of services. And so what we've seen, in fact, is very specific audits where they come in and say, hey, even though we're just a commercial plan, we'd like to see how you meet Medicare standards. And our response in those cases has generally been none of your business, but that is the way that some of these groups have come out and approached it. So keep that in mind, especially if you're dealing a lot with Blue Cross and Aetna in Texas is where we've seen it several times. One more issue. A couple more issues, sorry, is cross-plan offsetting by commercial health insurers. And I can talk about this really quickly. It's just kind of a fun case. What they did here was if nobody's familiar with cross-plan offsetting, that's where a plan, so for a good example is where there's TPAs, third-party administrators for employer plans. And so company A has a plan where they have a contract with the provider. Company B has a plan that they don't have a contract with the provider. And if the provider ends up caring for one of company B's patients, it's considered or employees is considered out of network. And if the payer decides it has an issue with the payment, somehow wants to seek recoupment, rather than just kind of dealing with the provider directly, what they'll do is go and offset payments under Plan A, which is really kind of disturbing when you think about it, right? And so because you're taking money away and kind of dragging into a dispute another employer and another patient related to something that was paid out of network for somebody else. They did this for a long time, though, and it was never enough money, I think, where anybody really got a ton of traction on it until one group had enough and they filed suit against United Health for it. And not only did the Eighth Circuit knock down the United Health's practice in this and say this does not compute with your contract, it's not allowed under your contract, and moreover, we're a little concerned that this might not violate ERISA, and that you are essentially what you're doing is transferring money from one plan to another, which is kind of a big no-no under the ERISA plan. So it's an interesting case, and if you are, I have seen this before where, I had a client call me up and say, man, I'm suddenly getting offset from this payer. We don't know what the heck they're talking about. We haven't had any problems. And then turns out they are offsetting them for some other claims that were out of network for a group that they never had a contract with. So it's problematic, and keep an eye out for those things. We've got about 5 minutes left, and rather than talk about Medicaid, because it's still there and it's very confusing, do you want to talk for a minute, Colleen, just go through some questions?
Do we have any in the queue or on email? First, I'll go to the queue, and then we'll see if we have any on email.
Can we open up the the line for questions?
Actually, none have come through just yet. They're topical. Actually, there was
Okay.
one that came through when you talked about the credible info slides. If you'd like for me to read that one off, I can.
Sure.
Okay. Oh, we are at the questions. Okay. So when you define how an overpayment is identified, the participant was wondering, is there a more firm definition around reasonably diligent?
I wish. What do you want to take that, Colleen?
Well, sure. So the short answer is no. There was some discussion in the preamble of that reg about, 6 months and things being reasonably diligent if it's less than 6 months. My view of it is it kind of depends on the situation you've got. If you have a very complex question, you've got a lot of review to do, a lot of claims to look at, a lot of issues to work through on a claim, then 6 months may be not enough. Other issues are more clear and less time is needed. But, the short answer is you have to keep working at it. And so letting things sit where nothing happens for months on end is probably not the best answer. But if you can show, constant progress of reviewing those issues, then I think, you've got a pretty good case.
Yeah, I mean, I always tell clients, if we're doing this, we need to be documenting some type of plan to look into it and documenting along the way what we're doing. Is it regular meetings? Is it meeting agendas? What is it that we could show if anybody ever came and inquired to consistently address it? Good question, though.
Awesome. Thank you for that. Also came through was you mentioned the American Hospital Association. I am new to the healthcare auditing space. Are there any other trade associations that you would recommend as well?
Well,
I know
obviously
one.
HFMA is a great HFMA is a great organization, especially if you're on the finance side. I don't know what this person's position is within their group. HCCA is another organization. That's the Healthcare Compliance Association. That's great for lawyers and non-lawyers, anybody who's interested in compliance. I always encourage people to, especially in hospitals, to be clued into their local group. So, for example, in Georgia, we have the Georgia Hospital Association. Colleen, I know you guys work with the Colorado Hospital Association.
Yeah.
There's a lot of really great state organizations too around your providers that support it.
And state chapters of HFMA too that are very active and really provide a lot of good content and good connections with other folks in the community. And typically, when one provider sees issue X, other providers are going to start to see it too. So having some connectivity to your local provider community is extremely valuable.
Mm-hmm.
Awesome. Thank you so much for that. Okay, there was a couple questions about the slides as well, so you don't have to wait for those. If you missed it at the beginning, we have some instructions for you. You can expand the handouts panel on the side of your screen and click on that PDF and get access to those right away. So as we approach the top of the hour, I do want to take this time to thank our members and the healthcare community for joining the call. A tremendous thank you to Polsinelli PC for sharing your thought leadership with our audience. As you exit, you will be prompted with a survey, and we really appreciate you sharing your feedback about today's event as well as other topics you'd like to see in future webinars. So again, thank you to our guest presenters, Colleen Faddick and Ross Burris III of Polsinelli PC. Any parting words, Colleen or Ross?
Well, thanks everyone for participating. We really appreciate it. You can reach us directly. I think our contact info is on the slides if you have any follow-up questions, and have a great day.
Thanks.
Thanks, y'all.
Have a great afternoon, everyone.